we'll go through this, and I think you'll really find this helpful and interesting. It's not only for throwers, this is really for any athlete.
Thanks, Eric. Certainly want to congratulate you and your staff, Ellen and everyone, Patty, on such a great course. I mean, it really came together nicely. It's a fantastic course. I like this course because it's, it's so much interaction and it's such a great environment instead of a stuffy meeting to say, to kind of summarize it. But great job with everything as always, Dr. McCarty. So I'm going to finish up the talk on throwers. We had a little computer glitch with the mouse and things of that nature. So when we deal with throwers, this is how kind of we think about it as far as an algorithm. Is the issue range of motion? Is it hyperlaxity? Is it tendinitis? Is it something going on with their cuff? Is it postural? Is it biomechanics? And obviously these overlap. And you see this with your regular patients, your impingement patients, your rotator cuff patients, and so forth. Are you kidding me?
So you go to plan B. I already planned.
You want to push the button?
I was pushing the button.
You want him to push the button?
Oh, no, I don't want to keep saying that.
So this is on. So anyway, I'm going to do like the talk show host. So if stabilization is an issue for the therapist, it's about proprioception, as you know, neuromuscular control, perturbation training. So we do a lot of this end range stabilization, a lot with muscle balance, your cuff, but also your deltoid, and body awareness. That's hips working with your scapula. If motion's an issue, obviously we talked about this a little bit. Is it capsule? Is it bone? Is it a combination of things? And we'll tease that out in a second. We'll show you how you can tease it out in about 5-10 minutes. So we want to work on stretching, joint mobilization, but you want to target the structures that are the involved structures. Posture. Most overhead athletes, now we're just not talking about throwers, just like Dr. McCarty mentioned, but cuff patients, overhead athletes, underhand athletes, whatever. Posture is probably an issue. And they're probably tight in their pec minor, right? Some degree pectoralis major, weakness of lower trap, serratus weakness. And that's usually what you can target and be pretty safe with it. So we'll talk about that as well through a couple exercises. Then the kinetic chain, especially with young people. They just don't get it, how important their legs, their hips, their posterior chain is. So this is a Major League Baseball player with a UCL reconstruction. He's doing a step down, he's doing lateral slides. He almost looks like a knee patient, but that's part of his upper extremity exercise program. And then biomechanics. We're lucky we have a biomechanics lab where we can film people if that's needed, or I just use my iPad and one of the video programs that you can use. I use Coach My Video. I have no ties to them whatsoever, but in therapy we do it with jump training, running, cutting, and throwing. So if I have an individual that doesn't look good with their exercise, I have to show them that. I have to show them what they're doing wrong so they can cognitively recognize it and make a change. You can say it, or you can put them in front of a mirror, but by the time they land from a jump or their throwing mechanics, it's already too late. They've already gone in and out of their bad position. So hopefully that makes sense. Obviously we deal with people with inflamed shoulders. Tissue regeneration is probably the biggest issue for us with overhead athletes in particular. So they've got a cuff that's thinning, they have cuff pain. What do you do about it? And that's where the biologics that Dr. Romeo mentioned earlier, whether it's stem cell, whether it's PRP, something to regenerate tissue. And we don't have the solution for that, but what we've gone to is a lot more submax, higher repetition exercise. It's a different exercise program than your traditional 3 sets of 10, I'll tell you that. You're doing 15, 20, 30 reps at a time in a particular set. We've also gone to blood flow restriction, like we talked to the staff last night, in those individuals where we do a restriction in basically your circulation to the extremity to try to cause more tissue hypertrophy. So for the rehab people, obviously, we talked about retroversion and all these types of concepts. So if a thrower or overhead athlete, could be a volleyball player, could be a softball, whatever the case may be, in this case it's a baseball player, comes in your PT clinic or your athletic training room and you see this, how do you know if it's bony or soft tissue? So obviously, you get an MRI, you can measure retroversion, but not everyone's gonna have that. We don't do that in Birmingham. So the first thing I would recommend to the rehab people is bring their arm up, align it with the glenoid fossa, center the humeral head. If they have laxity posterior, they're already going to sit posterior. So align the humeral head in the center of the glenoid and translate it posterior lateral and see if the posterior capsule's tight. If the posterior capsule's tight, you would do joint mobilizations. Next, I would measure the retroversion. And instead of doing an ultrasound, which is a great way of doing it, and then like Dr. Noonan mentioned, it really only takes about 5 minutes, but you have to have an ultrasound, and you have to be fairly good at it. You have to do enough of them. So what we do is we just palpate the bicipital groove, and there is a paper published out of the Ohio State University, that actually showed palpation can equal the ultrasound findings. So we palpate the bicipital groove, we rotate the arm until the greater tuberosity and lesser tuberosity on palpation is parallel, and then you have a second person with a bubble goniometer measure that retroversion angle. And then you would compare it to the opposite side. So you correct it for bone. And it literally takes about 3 minutes, honestly, once you do this a couple times. Then what I would do is take a look at posterior musculature. You already assess the capsule, stabilize the scapula. That's what I'm doing with my right hand. I'm bringing his arm across the body, and I'm looking at how far does he go. In overhead athletes, we want 40, 45 degrees of horizontal abduction. If they do not have 45 degrees of horizontal adduction, we assume that there's tightness in the posterior shoulder. And then take a look at the scapula as well. And then based on your findings, you would treat those things. So treat the findings. Also, for those of you that see hip patients like I do, the bony changes that happen at the shoulder in throwers happen at the hip as well. So just like you have GERD and retrotorsion or retroversion, whatever you want to call it, at the shoulder, you have the same thing at the hip, and we published a paper on that a few years back. All right, so exercises in the last 8 minutes. I'm watching my timer here. I got you covered. I know you're a union, so. So stretching. You go to a Rockies game. You go to the Rockies game, and you see someone stretching like this. And this is okay as an active warm-up, but if they're tight, that's not a great idea. So what we try to do is stabilize the scapula. Sleeper stretch, cross-body stretch. So we'll give you some numbers on this. So here's a professional baseball pitcher. He's bringing his arm across. Look how far he goes. Certainly looks like 40 degrees. Probably looks a little more like 60, right? But his scapula is moving. Throwers have a tendency to have their scapula protracted, anteriorly tilted, and internally rotated already. So all he's doing is producing more protraction. So I come in, I stabilize the scapula, and look, I've lost 20 degrees of motion probably just by stabilizing the scapula. And you all know this, the rehab people know this, but individuals that are stretching on their own, it's hard to stabilize the scapula. So this is what I do in the clinic. I do a stretch or two across the body, but really my go-to stretch is angle it toward the opposite axilla, because I want to get a stretch on the posterior musculature. So when you throw, we talked about this eccentrics. So the back of the shoulder gets tight. So now I'm angling it, as you can see, toward the opposite axilla. I'm internally rotating at the same time, so I get a target stretch on the posterior musculature. And by the way, if the posterior band of the inferior glenohumeral ligament complex is tight, I'm going to get a stretch on that too. So if it is capsular. You can certainly do sleeper stretch, and I'm okay with that. But what I like is a modified sleeper stretch, where instead of being directly on their side, they do a quarter turn. That way they're in the plane of the scapula. I think it's more tolerable, it's more specific to their shoulder, and they don't irritate the anterior superior shoulder aspect. Same thing with cross-body stretching. You can't do this on the field, but you can certainly do it in the training room, you can do it in your home, you can do it in the PT clinic on your own. What stretch is better, sleeper or cross-body? McClure and JOSPT in 07 showed that cross-body stretching was better than the sleeper stretch in healthy individuals. Muscle energy, contract, relax, is a better way of stretching as well. And 3 stretches for 30 seconds in a Division I baseball team was proficient at maintaining range of motion. We also do corner stretches. We think this is the best way for pec minor, provided it's done the right way, as well as pectoralis major stretching. So, enough on stretching. What about muscle in the last 5-6 minutes? So muscle balance is important. Balance in the shoulder, balance in your body is very, very important. So we look at ratios, ER to IR, ER to deltoid, scapular ratios as well. We use muscle stim on the back of the shoulder as well. We do a lot of manual techniques as well. We publish this is on our website, the Throwers 10 exercise program. You can look it up on asmi.org. And it's a nice entry level to intermediate phase exercise program. So I don't want to really spend time on it. I want to talk about advanced. How do you move somebody along a little bit more? So a few years ago, we came up with what we call the Advanced Throwers 10. And the goal of the Advanced Throwers 10 to work more end range and more endurance training. Because we already said when you fatigue is when injury rates go up. Last quarter of the game, last innings, last ski run, all those things that you hear. So these exercises are okay in the beginning, but that's really not where we want to be. We want to be on the stability ball. We want to do higher repetitions. We want to activate the scapular muscle as much as the shoulder, glenohumeral joint. This is a lower trap exercise, but as I mentioned before, you actually get higher EMG activity of your upper trap versus your lower trap. This is a picture from Dr. Kibler's work. This is called the robbery. This is our modified robbery. This is what I would recommend to you. I think it's a better exercise than the one on your right. If you look at Dr. Kibler's EMG activity, it actually gets higher upper trap than lower trap, as we talked about. If you want to activate lower trap in your general ortho patients, this is actually a very good exercise. I use this all the time. Person's seated, hand on the table, and they just press down. You can do it with a bent elbow as well. It's solely lower trap. You don't get anything else, provided you do it the right way and you're not hiking your shoulder. So from an activation exercise, very, very good. A lot of times I'll do lower trap. Dr. Preventure was talking about AC joint problems. This guy has an unstable AC, and I've taped his AC joint with Meccano tape, and I've used KT tape on his scapula because he has scapular dyskinesis because of the AC joint instability. And here he's doing a lower trap exercise. We talked about these wall circles before. This is our neuromuscular exercise, and this is a takeoff of the Feldenkrais exercise, if you're familiar with from years ago, movement awareness. Person lays on their side, involves side up, hand on the table, so you fix the distal segment, and it's slow protraction, retraction, elevation, and depression. We would do this with manual resistance and verbal cueing, and then we'd ask them to close their eyes and do multiplanar, diagonal types of movements. Tough movement, and the hand on the table just isolates proximal. All the exercises are done bilaterally, otherwise you end up like that. But throwing a ball is bilateral. You use your opposite side of your body to propel your arm or to activate your internal rotators. So this is where we start someone, down at the zero position, even though they may be throwing up at 90, and then we'll bring you up against gravity. My hand on his shoulder for the rehab people is I'm trying to roll him forward so he's got to retract at the same time as external rotate. That increases your EMG activity of your posterior cuff. Then we bring you up to 90-90. This is where the rubber meets the road. Can you do this? Can you do this without pain? And if you can't, well, you certainly can't throw in my mind. That means we have to bring you back down and address why you're having pain up at 90. But I will tell you, it's pretty unusual. Then we'll go eyes closed. So he doesn't know. So he's externally rotating against manual resistance, TheraBand. And then he gets to end range, and I try to push him further back, and he has to stabilize. So it's an end range stabilization exercise. Now I'm asking him to turn his head away so he can't see. He's also on a balance beam, but you can put them on foam. Something to bring the core of the body into the equation. Sustained holds. So we wrote a paper on this a few years ago. We said baseball players and overhead athletes need to be challenged more. Then doing this with a 3-pound dumbbell isn't enough. So we want to build endurance. So here's a guy seated on a stability ball. That's a 4-pound dumbbell. So he does his traditional full can, stopping at 90. On the 10th rep, he'll hold on one side, and he'll move the opposite shoulder. So he's going to stabilize on one side. It's called a sustained hold. We want him to maintain good posture, posterior tilt of the scapula, retraction, good lumbar lordosis, good hip control, and he moves this side. On the 10th rep on this side, he'll hold, and he'll move the opposite side. This doesn't seem like much until you ask your patients or you do it, because it's an endurance. It's a postural exercise. You're maintaining the position. Suddenly, that 4 pounds gets super heavy when you're holding it there for about 20 seconds. Then what we'll ask them to do is, obviously they can do tubing, but we'll do prone exercise, like prone tees. First set, it's all about posterior chain. So posterior hip, your hamstrings, erector spine. And I'll tell you, high school kids, even your best athletes, are generally going to be weak posterior chain. They cave over the ball. And so the whole time of this type of exercise, I'm saying to them, keep your hips straight, lock your knees out, stay extended, because they just collapse, they fatigue out. And that's only a 3-pound ball. This is a professional baseball player outfielder who never met a mirror he didn't like, trust me. And he usually walks by it, and he's checking out his posterior chain, always. And he's all tatted up, and he's really into it, trust me. Here's a high row, at least that's what we call it. So you're getting rhomboids, posterior cuff. So we do this with TheraBand, but we'll add in maybe cable column, manual resistance as well. But it'll do a hold on one side, a lot of planking. So here's one of our strength and conditioning coaches. So this guy's in shape, right? Works out all day with kids, really pushes the envelope. So here we're planking it out, and the indicator is that Alabama jersey and that face. You'll see that 2 colors will match shortly. Also the vein in his forehead. So now I'm going to add in some manual resistance. So my hand on his shoulder, I'm trying to roll him forward. The whole time he maintains the plank, and I add in an end range rhythmic stabilization. So I'm just trying to take one exercise, sideline ER, and add another level of difficulty, another layer, another layer. Why? So his body doesn't go to sleep with an exercise he's been doing for 3 years. Does that make sense? Especially these throwers, trust me, they've been doing the same doggone exercise forever. They just go to sleep on it. So here he's got a piece of TheraBand CLX. I'm enjoying it. His face is getting redder.
Yeah.
And I do an end range stabilization. And you can see his face. I mean, he's getting into this, and this guy's in shape. He's not injured. He's not having a problem of any sort. So now here's a 2-pound ball. So now we get an eccentric contraction as well. So we love these planks, especially female volleyball players that we worry about with landing and hip control. Now he's got TheraBand, ball, and stabilization. He's freaking. And the next day it was funny because he goes, "You got me." And I said, "What do you mean you got me?" "Shoulder, man, I was a little sore. I even felt it in the hip." I'm like, "You, of all people, you felt it?" Because I took him out of his element, right? So here, this is a pro baseball player coming back from a UCL. That's a 2-pound ball. Look at the difference in technique. This guy's rock solid. We talked about the lower trap activation already, these wall circles. Wall slides are great. If you're dealing with overhead athletes, this is the best way. Second highest EMG activity as far as a muscle in the upper extremity in a thrower is serratus anterior. That downwardly rotates your scapula. That's where you're getting your power from. If your scapula is lagging behind, you cannot accelerate the arm. And that's really what it's all about. Stretch shortening, plyometrics. So here he's doing a wall slide. I'll show you this last one here. And I just want to mention one last thing about weighted ball throwing, and then we'll wrap this up. So now I'm going to add in TheraBand. This is our strength coach again. So we just use a pillowcase or towel up against the wall just to decrease the coefficient of friction. So now I have silver TheraBand, second strongest. So this is CLX again. You notice there's big strands left behind here, and there's a reason for that in a second for the next exercise. The study by Sharman out of WashU showed that you have to go above 90 to get your higher level of EMG activity of your serratus, by the way. So now what I'm going to do is I'm going to grab those extra strands of TheraBand and I'm going to pull on them so I'm resisting his protraction. This is tough. This is a tough exercise. I don't know if you can tell, but you're starting to exert a little bit more force. So we can make this much more difficult. I can come in and resist this arm on the way down. Last thing I want to mention was weighted ball throwing. That's a hot topic right now in overhead athletes. So we've been doing plyometrics for a long time, probably 20 years, 2-pound ball stationary. But now the trend is that you would use a 1.5-pound baseball. And you would back up and you would throw that into a rebounder. So it would either be overweight or underweight throwing. There's been several studies on this. One from Hawaii, from Coop Durant from the University of Hawaii. And actually what's been shown through numerous research projects here in the United States, it actually does increase ball velocity. But it also increases stress on your elbow. And that was a study we just did at our institution. So the bottom line is this was something that was done in the I said because Coach said Devil Rays organization last year in the minor leagues. If you do a weighted ball program or you have a patient that wants to do weighted ball throwing, the real key with this is And what the Ray showed is it has to be monitored by somebody that knows something about mechanics. So either a therapist, coach, or a trainer that's watching the person, because when they start throwing a weighted ball, their mechanics tend to change, especially in kids. They start pushing it, they drop down, they open up. And that's where we think the increased stress comes in some of the problems. So with that, I'm going to end there. And again, Eric, thanks so much for a wonderful conference.